Perfect. So I shall get started. Good afternoon, everyone. And it's just good afternoon because we've just hit 12 o'clock. My name is Carly Marge, she, her pronouns, and I am the Rules Services Development Coordinator for the Centre for Excellence in Rural Sexual Health. I will say SERSH. I would like to welcome you all to the Understanding Bacterial Vaginosis webinar, which is part of the SERSH's Sexual Health Month activities and presented by Associate Professor Siobhan Bourke, who I'll introduce very shortly. But before we begin, I would like to acknowledge the traditional owners of the lands and waterways across Australia from which we are all joining this afternoon. I pay my respects to elders past, present, and emerging, and I extend that respect to all Aboriginal and Torres Strait Islander peoples with us today. I also acknowledge the deep importance of Indigenous knowledge in the field of sexual and reproductive health. Wherever we are zooming in from, we are on Aboriginal land and sovereignty was never ceded. Just a few housekeeping notes before we begin. We kindly ask everyone to stay on mute during the presentation unless Siobhan has some questions or a discussion she wants to do. But please feel free to share your questions in the chat and we'll absolutely do some questions at the end if we have time. This session will also be recorded and will be available on the SERSH website next week, and we'll probably put it in under the PD Wellness Series page. Okay, let's get to know our speaker. I would like to introduce Associate Professor Siobhan Bourke. Siobhan is a sexual health physician who is the Director of the Sensitive Physical Examination Program in the Department of Medical Education. Siobhan is also the topic lead for the sexual health across clinical context discovery subject across MD 1 to 3 in the Department of Rural Health at the University of Melbourne. Her passion is to educate pre- and post-registration health professionals in the art of clear communication in sexual health care. Siobhan also works clinically at a community health centre in Melbourne's West. So thank you, Siobhan, for presenting this afternoon. Over to you.
Thanks so much, Carly. I hope everybody can see my slides. I'll just get them onto presentation mode. Can everybody see those? Yep, excellent. So understanding bacterial vaginosis is actually a really big ask. I remember going to a conference probably back maybe nearly 20 years ago and listening to a speaker who'd done research on bacterial vaginosis for over 30 years and still don't have an answer. We now don't actually have an etiological specific answer to bacterial vaginosis, as I'll go through, but we do have some exciting new management and treatment. So let's get moving. Sorry, I'm just expanding. Okay. Like Carly, I'd like to acknowledge that we're all meeting on unceded lands of Indigenous people. And I also like to remind myself that education has been going on for thousands and thousands of years. And I hope that with our discussions and talking, we're able to extend the kind of knowledge to everybody present. So my first... Oh, that's interesting. It says title goes here. Clearly that got missed. My first slide just wants to actually acknowledge this is the work of two very special people that actually live right here in Melbourne. So of all the research that's done on bacterial vaginosis around the world, this has been really groundbreaking from Melbourne Sexual Health Centre. And so we have Professor Katrina Bradshaw and Lenka Vodstrel. I'm sure I have not pronounced that correctly. They have done some groundbreaking work on bacterial vaginosis and partner treatment, which we will go through. And I want to acknowledge that the slides that I have been, that I've developed have really been, the information has been derived from these two quite amazing people, and their team. There's a lot of people who go into their team. If you want to know everything that you need to know about bacterial vaginosis and probably a little bit more, read the Bradshaw et al. Bacterial Vaginosis Nature Review Disease Primer. And so the reference is there. But if you Google that, it is a fabulous document. And I've just brought out a few slides from that. Using that document, and also some information that Katrina and Lenka actually supplied for me. So just so that what is bacterial vaginosis? So really it's actually kind of a syndrome. And as we go through, I think you'll realise that it's a syndrome that's been misnamed and therefore has increased the burden on people who actually own vaginas around this infection. So it's a disorder of the vaginal biome. And it's an inflammatory process. There's lots of cytokines and things, and we get sorry, if you can hear my dogs, they've just had a bit of a grump behind me. So it's an inflammatory process. There's bacterial proliferation, and really it's kind of the way I describe it often to my patients is the good bacteria have decreased and the not so good ones have increased. And so, but we do not have one specific etiological agent. A lot of people will talk about Gardnerella as the etiological agent, but it is actually in a suite of a whole variety of different bacteria that occur. So it is really high in prevalence. It's the common thing that I will say to patients is 1 in 4 people will probably get bacterial vaginosis who has a vagina, have bacterial vaginosis in their lifetime. But so that's kind of a quarter of people globally. And this, when I talk about a quarter of people, I talk about a quarter of people who have vaginas. When HIV is present, that can actually increase up to 50% of people with vaginas can have bacterial vaginosis. And in pregnancy, it can be noted between about 12 and half of people. And you can see there from the slide that we have on there that the prevalence is really high. And there's multiple graphs within this document, and I just sort of brought out the one about people in pregnancy. So there is quite a variety in the presence of bacterial vaginosis. So what we used to say is that it's not an STI, it's related to sex, but it's not really an STI because we couldn't find this etiological agent, and we couldn't actually find this agent particularly on men. So we haven't got the ability to test someone who owns a penis as opposed to someone who owns a vagina. Basically, it was protect yourself with barriers as best you can. And the reoccurrence is high. And I'm sure as I'm talking to lots of clinicians, that one of the things that you diagnosed someone with bacterial vaginosis, and it was a real heart sink trying to be positive about treating them with antibiotics, etc., but sort of knowing that the recurrence rate was around about 90% at 3 months, which is really quite demoralising. But what we can say now, it is the burden of people with vaginas, and that's probably because of the name. Now, I'm not going to suggest, I don't know enough about this to suggest a new name, but I think it would be interesting to come up with something different that doesn't just directly say that it is only vaginas that get this. And it is basically the burden of people with symptoms. So people who don't have vaginas, who have penises, can actually have obviously the bacteria and the thing that can actually transfer this to people with vaginas, but they don't get the symptoms of it, whereas people with vaginas do get the symptoms. The big thing is, and I think really what Katrina Bradshaw and her team did was think about this in a different way. Let's not try and find the Oh, someone's got their sound on. Let's not try and find the etiological agent specifically, because obviously this has been a real problem over the last 30, 40 years of research. Let's try and work out if by treating male partners or partners of people with bacterial vaginosis, do we actually decrease the persistence of the bacterial vaginosis or the reoccurrence of the bacterial vaginosis in the people who had the symptoms. And that's where their research has really been groundbreaking. So, as I've said before, it is sexually transmitted that we know now, but we can't identify one particular pathogen. So how do we identify bacterial vaginosis? So the signs and the symptoms, people will be coming in and describing the issue of having a smell, a vaginal smell. Often it's sort of described as fishy. It's often white or greyish. It tends to be thin, so that's sort of the differential between acute thrush. So it tends to be thin, and people can complain of itch and irritation due to the discharge. And I'd employ any clinical person here that one of the things that you need to do is you need to look, and then you need to test. And some of the things that we can actually do within our clinic rooms is we can actually have a look at some of the parts of the Amstel's criteria. So the first two is we're observing that there's that type of discharge. And the second thing is that we can actually test some of the discharge on like a litmus paper and just check to see whether the vaginal pH has gone above or is equal to 4.5. And those sorts of tests are actually very, very simple and can give us a start. We also can do a swab of the discharge and send that to the lab, enabling them to do a gram stain. If you have your own microscope and you're really, really keen and you know how to do wet preps, you can actually prepare a slide and have a look down the slide. And what you'll see are clue cells. Now, this was one of those aha moments for me a little while ago while doing some reading on bacterial vaginosis, is realizing what a clue cell is. I have looked at clue cells for the last 20 years, particularly when I worked at Melbourne Sexual Health Centre, and you'd prepare a gram stain, you'd go down and you'd see these nice big squamous cells covered in bacteria. And so what I was looking at was, because of that inflammatory process in the wall of on the vaginal wall, the bacteria and the inflammatory process is causing the squamous cells of the vagina to slough off, and a clue cell is actually looking at those squamous cells, and they're covered in some of the bacteria, normally gram-negative bacteria. And so that's what you're looking at. There's also this not so pleasant test to do, but it is possible to do in your rooms, is with a wet prep of the discharge. You can actually do what they call as a whiff test, and that's you drop 10% of potassium hydroxide onto the slide, and you get really a very strong smell of that kind of fishy odor. So that's another part. When we send our samples off to a laboratory, they will have a look, do a gram stain, but they will also look and grow and see what type of bacteria. And one of the most common gram-negative bacteria's presence is Gardnerella vaginalis, but there, as I said before, there's multiples of others. And the other thing that you are seeing is the lack of lactobacilli. So that's how we identify it. And why do we worry about it? So this has taken a lovely slide that sort of demonstrates what's going on here. We have BV, bacterial vaginosis. All this material is sloughing off from the vagina, and it can actually go higher. But when you have an inflammatory process within the vagina, this actually increases the risk of accumulating or getting other STIs. So it makes it easier for an STI to be transmitted and to enter the body. So the protective layer, the mucus layer that can sometimes protect against that is less. And so those STIs can be all manner of STIs, including, importantly, I think, HIV and also human papillomavirus. So there is an association with increased rates of human papillomavirus being accumulated, and therefore that actually increases the risk of cervical cancer. Other things that you can actually see is that it can cause increased infection in the upper genital urinary tract, and this can also be an increased inflammatory response, so we end up getting blockage of the tube, so that can lead to pelvic inflammatory disease, and a further sequelae of that can be the risk of infertility from if those tubes remain blocked. And also, this process can actually be increased when we don't screen or treat for bacterial vaginosis while doing operative procedures, and so therefore might increase the PID and then potentially the risk of infertility in blocked fallopian tubes. Some of the other, sorry, I should actually go back if I can work out how to do that. Yep. One of the other things is that during pregnancy, that people with bacterial vaginosis have an increased rate of preterm birth. So therefore, that can raises the complications of having a preterm baby. So then, when they were thinking about how it is to look at this, they thought about, let's see the treatments and let's see whether treating a partner can actually decrease the rates of bacterial vaginosis and the reoccurrence rates of bacterial vaginosis. So that's the important thing. And I think they like to talk about the persistence as well as the reoccurrence. So did people fully clear it and then get it back, or did they clear it, or did they not fully clear it because their partner hadn't cleared it, and then the infection persisted? So the treatment for people who have vaginas is no different to what we've been prescribing before. So the treatment guidelines on Melbourne Sexual Health website and also the STI guidelines for people with vaginas will say things like this. So metronidazole, 400 milligrams twice a day for 7 days. I often find that with my patients that after they've done that once or twice, they get a bit bored with that, and so they want to go to cream. But remember that the cream is not on the PBS, so therefore this will be a more expensive option, and you can use clindamycin or metronidazole gel into the vagina as shown there. Well, the things that we talk about when you're giving someone metronidazole is that it can cause nausea. I'm sure we're all aware of that, and particularly nausea with when drinking alcohol. And that can make people who, drink half a glass of wine, make them feel like they've drunk a bottle of wine. So you have to be really, really careful with metronidazole. Have it with food to decrease the nausea. And it can also cause headaches. There's a little bit of vomiting, very, very low rates of that. And then also things like a metallic taste. A certain percentage of people will get this metallic taste from metronidazole. Don't know whether any of you have ever had it, but I certainly get a metallic taste, and it does not go until you finish taking the medication. I tell my patients you can choose chewing gum, but as soon as the flavour's out of the chewing gum, back comes the metallic taste. But I think, like with most things, is if you warn people of it, they're far more tolerant of those kind of side effects. We recommend to people to avoid sex. Use condoms strictly, as in you must be wrapped in rubber before you touch anybody else, before you have any sex. No, just putting condoms on for ejaculation, all that sort of stuff. But if you are using vaginal creams and gels, it may actually weaken the latex of the condom. So if that's your only form of contraception, we need to be aware of that. Douching under any circumstances, but particularly when you've got bacterial vaginosis, should be avoided. And also douching can actually make bacterial vaginosis worse. And then we have the new kind of groundbreaking guideline is to treat partners. Now, at this point, the partner treatment and the research has been done on cisgendered heterosexual couples. So this is talking about treating people with vaginas and their partners with penises. They are doing further work on treating people who have partners who have vaginas. I think you probably talk to a lot of us and say that many people have been treating people with vaginas and their partners with vaginas for years and years and years on bacterial vaginosis. So, I don't think it's that great a leap for us, but the research has never actually been fully concluded, particularly with this type of research. So the people with penises are asked to take, they have to do a little bit more. So they're asked to take metronidazole, as their partners do, and a clindamycin cream. And they need to apply this to the skin twice a day. Now, this is not on the PBS, so it's more expensive. So it's best to synchronise the treatment. So let's both start taking our metronidazole tablets on the same day, and both partners to then use that for the subsequent 7 days, and while the person with the penis is also applying the cream twice a day. So you need to obviously provide really strict medication directions. And then also, when you write a script for clindamycin cream, it is clindamycin cream that is for a vaginal preparation. So it comes with a tube and applicators. Pharmacists can get quite confused. And Katrina was telling me about how people had come back and said that the pharmacist wouldn't give me the cream because it's for a vagina and not for a penis. So they've actually developed a letter to actually explain this, so that when the person is purchasing it, they know that that they're using it topically. So the instructions basically are that you put this much, so from the tip of your finger to the first joint, is you put that much cream, and that has to be placed over the head of the penis, under the foreskin if there's a foreskin, and make sure that they give that a good smearing around that whole area. And then also put a second lot on, and that goes over the shaft of the penis. Now, they have found that when both those treatments are done and done fully, sex is avoided for that period of time, that the rate of reoccurrence of bacterial vaginosis is significantly reduced, and to the point where they sort of had to end the trial early because there was such a difference between the control group and the treatment group. The interesting part is the people who got rebound reoccurrence or potentially persistence of their bacterial vaginosis occurred in women whose partners were not really good at doing the cream part. So I think one of the skills that we need to develop is being able to encourage people with penises to make sure that they are doing that twice a day for 7 days. The rate of any penile skin irritation was actually very low. So we should, sort of say that really this was not, there weren't many side effects associated with using the cream. Most of it is associated with using the metronidazole oral tablets. The cream was very well tolerated. It's just, how do we make them remember to do it? So Katrina and Lenka were interviewed by the New York Times, and it's kind of gone all over the world. So I think it's really, really groundbreaking. We should congratulate them for doing that. The guidelines on the Melbourne Sexual Health website have changed, so that's probably the place to go to at the moment. The Australian STI guidelines are yet to change. So I think that will be coming through in the next wee while, but it just takes a lot longer process to change those guidelines. But really, if you head to the Melbourne Sexual Health website, you'll get great guidelines and information on treating partners and etc. for bacterial vaginosis. So as I alluded to before, what do we do for patients with partners that don't have penises? And I think treatment at time is probably what's going to be the recommendation. And I guess it's kind of convincing people whether without symptoms, whether they get, whether they take the treatment. The tricky part, I think, is always going to be is what do we tell people with casual partners, and how do we get people with casual partners to treat their partners? So as yet, that contact tracing issue hasn't really been sorted out. The recommendation is to treat regular partners. The recommendation is to treat multiple regular partners if you have multiple regular partners, but that actually gets quite tricky with its management. But these are sorts of things that we have to kind of work our way through, I think, but well and truly worth doing it because of all the sequelae of BV. So as I alluded to before, problems along the way is during the studies, patients were more likely to clear their BV if the partner took the full treatment, and the cream had the drop off. And how can we assist with that? So one of the other issues that has come up is that having an intrauterine device can increase BV, but particularly associated with copper IUDs. One of the interesting bits of research is that if you remove the copper IUD, the person will actually, after a year, will actually be right back in and getting the same rates and recurrence as BV. So I think really it's all about clearing the BV from the person who has the vagina and the IUD in and clearing it from their partner. We need to be really careful about, removing an IUD for the reasons of bacterial vaginosis, without actually ensuring that we've got good contraception in place for the person if that's what they needed. They have found that that some of the bacterial vaginosis might be harder to treat, and that might be because of partners not being treated, and also because of the actual physicality of the string, and that's where some of the bugs are hanging out. So it's whether we need to watch this space in research to see whether treating both the partner and the person with the BV and the IUD is enough, or whether we have to extend treatments for people with IUDs. So that's another kind of watch this space. At the moment, last week in the ASHM conference in Adelaide, the Sexual and Reproductive Health conference in Adelaide, there was a discussion about other IUDs, and I think that's another watch this space. We do tend to find less bacterial vaginosis with people with hormonal contraception, but the hormonal IUD is kind of has that mixture of hormonal contraception, but also has the string. So the jury is a little bit out on whether it's better off, your IUD choice is better to be hormonal rather than copper to protect against bacterial vaginosis. Personally speaking, I think what is really going to happen is we're going to see is the decrease recurrence or persistence of BV when we're treating partners. I think that will probably be our mainstay. So I just want to make sure, don't let this be one of the reasons that we don't prescribe, insert, etc. IUDs. I think we need to be a little bit more clever because there's such a good form of contraception. And obviously, as we all know, being pregnant when you don't want to be pregnant has multitudes of issues. So one of the things that I wanted to do is to see whether anybody had any ideas about explaining how this would happen. So I wasn't sure how many people we were going to have here, and whether people would feel comfortable in putting in the chat how it is that they might explain these kinds of questions. So how is it that people have explained BV in the past? The reason you can turn your cameras on if you want to. If you don't want to, you can just sit there and have a lovely lunch and listen to me rabbit on. One of the things which anybody who knows me well enough will know that one of my passions around sexual health is really around communication. And one of the things that I hear a lot is if someone said to me, how do you explain BV? they would give me a list of what it is. It's an inflammatory process that people with vaginas get. It's caused by an increase of good bacteria and or a decrease in good bacteria and increase in better bacteria, causes a discharge, whatever. But I think one of the difficulties or one of the skills that we gain when we're good at sexual health communication is working out what those actual sentences are that we would say. So I'm just trying to get up the chat, whether there's anything in the chat. So one of the one of the things that I was just trying to get across was what would be some of the sentences. How is it that we all describe bacterial vaginosis? So does anybody have any real pearls or little sentences that they actually say about how they explain it to patients? Do you want to pop them in the chat? If you want to. I'll give you a moment. This is those uncomfortable silences where I like staring at my medical students.
Can you
And they
see
get,
the chat, Siobhan, or do you want me to read
I
out the
can
comments?
I can see the chat.
Great.
I use the internet. I had good bacteria off balance. We use visualized little blobs. That's great. Okay, so yeah, I use the expression like this is, we're not actually sure. It's not an STI. It can cause offensive discharge. So the imbalance of bacteria that normally lives in our vagina, yeah, I think that's a great one. So we need to make sure we change it. It's not an STI where we can say this is the bug, like it's not chlamydia or gonorrhea, but it still is sexually transmissible and it is an infection. So that's one of the things that we kind of need to change. And we can't just do directly, one test to say you've got this bug, but we can do it. I would explain it as one's flora getting off kilter. That's a great expression. And in the past, I would have said it was an overgrowth of bacteria, and I would only recommend treatment if symptomatic. And now I'm not sure what to say. Okay, so I would say that it's important about protecting people against other other STIs. So the times when we would do a test for BV is if someone's symptomatic. So therefore that's easy to say treatment for their partner is when you might be doing a pre-procedure. And that's when I think it's really important to explain what are the consequences if we don't treat that. And so therefore I would treat that. But to reduce the recurrence rate of persistence, I would be treating the partner. So that's how I would change that, if that makes sense. And the other time we might be doing it is during pregnancy, and because of the issues relating to the preterm birth and other sequelae during pregnancy, is that then that's when I would be thinking about how do we actually treat it. And that's when you might turn to the creams, etc. But now the treatment of partners as well. Okay. Where are we up to? Explain the vagina is not a sterile area. That's exactly right. The vagina is not a sterile area. And so therefore our procedures, when we take a pap test, etc., or doing a procedure like taking samples because of someone is doing it, it's not a sterile procedure. We don't use sterile gloves. We use gloves, but we don't use sterile gloves. We change those to sterile procedures when we're doing operations. And so, so they've gone good bacteria decreases. This can occur when we have intercourse. So yes, so there's an exchange of bacteria. And so therefore it reassure that it does not mean partners have caught it from another sexual partner. I think this is where our thinking needs to actually change a bit, is that we now have evidence that it is in both partners. So that is where we need to say, that there is this exchange of bacteria. It's changing, it's causing an inflammatory process within the vagina, and therefore we are actually picking up something that is being exchanged between partners. So it is, in a way, a sexually transmitted infection or inflammatory process. And so the importance of treating the partners. And I think that's really, really what we kind of want to get across, and that's what people will be talking about, I think, for the next few years, to trying to work out how it is we explain something like this when we don't have a specific bug and a specific name. And that's really where the skill comes in. But if partners are not treated, the recurrence rates are going to remain extremely high, or the persistence of BV. And because the symptoms are associated with someone who has a vagina, the burden is basically on the person who has the vagina. But it doesn't mean that the person who doesn't, their sexual partner, is not actually transmitting and giving them something. So that's kind of going to be the skill. So actually had a cis male coming in on the advice of his partner whose BV lives in China, asked for treatment. He was aware of the study. Excellent. So that is good. And if, it can be a perfect time to actually treat someone if they're actually apart. And so they can be treated, and therefore if they're not having sex together, make sure they're not having sex with someone else. But the reality is I think more and more people will start hearing about this and will actually be requesting the types of treatments for people with penises. So I think this is kind of, it will actually eventually get us. So I just wanted you to think about what are the treatment methods, how are we going to explain them, all those sorts of things, to actually start really thinking about those sentences and the way that you describe it. But I will actually, I'm just going to decrease the, okay. So really the other thing I was thinking about is I don't think that everybody is probably clinical on this, on this talk today. And so what are some of the other things that might need to be done? And it's like products, we need to produce resources so that a lot of this can be explained. We need to be able to, as health practitioners, be able to explain it. We need to have information within clinics, and we need to be able to have things that are really patient appropriate. And so we can direct them to places where they can actually pick up some information in their own time and think about it. And luckily enough, Melbourne Sexual Health Centre has basically done a lot of this for us. So we've got some great videos of cisgendered heterosexual couples talking about bacterial vaginosis and the treatment and how they've kind of done it together and the ways that they think about it and the importance. And so I think kind of watching some of this sort of stuff might be really valuable for patients. And the other thing is they have lots of information for patients, have lots of information for practitioners and how to actually describe it and what all these things are. So they've got a special little part of their website, which is the bacterial vaginosis part that gives all the information for patients. So, I think we can use that. I don't know whether people can pick up that QR code from their computers, but hopefully they can. But if not, it's easy enough just to have a look at the Melbourne Sexual Health Centre and you'll get there quick enough. So that really was the end of my little bit of a rant to try and show you the importance of bacterial vaginosis, some of the sequelae if it's not treated, but how we actually might be able to reduce the burden of people who have vaginas on this inflammatory process that's going on. And I really wanted to thank Katrina and Lenka because they were very, very generous in sharing all their information. And, if you have a spare hour, read their primer because it has all the bits and pieces that you'll ever want to know. So thank you. I don't know whether I'll stop sharing.
Fantastic. Thank you so much, Siobhan. There is a couple of questions in the chat, so I'll read that out.
Yep.
Sarah asks, does the inflammation from BV make people more susceptible to, sorry, I can't speak, to an STI if they were exposed? Sorry if you've already covered this.
Yeah, like I said this right at the beginning is, and yes, it does. And so so this is one of the importance parts of it. So the inflammatory process can increase your risk of obtaining other STIs, and of particular note, HIV, and also the and human papillomavirus. Now, human papillomavirus, we're very, very lucky in this country to have vaccination so that the rates of that, and particularly the rates of the oncogenic types, are reduced. But we do see that people with bacterial vaginosis, particularly in areas that don't have vaccination, have increased rates of HPV, and as a consequence, years down the track, increased rates of cervical cancer. So it is really important. You know, it's another reason to actually treat. No one wants to have BV who has a vagina. Like, it is not a pleasant thing to have. But I think, you know, it is one of those things that hopefully there's a little bit of hope at the end of the tunnel, that if we can actually treat people and treat their partners, that we will actually reduce this burden.
Great. I'm not sure if you have the chat, Siobhan, but there's a
Yeah.
few others that are coming through.
Yeah.
Someone else asked, could you please say again, would you also treat partners even if people with vaginas are asymptomatic?
So if so say you were screening them for whatever reason, an asymptomatic person with a vagina, they're pregnant, blah, 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 got BV, yes, treat them, treat the partner. If you don't treat the partner, even with asymptomatic, it's going to come back and recur or persist. So we have to start thinking that whatever it is that is being exchanged is still being exchanged if we don't treat both the people.
Great.
I hope that makes sense.
Melanie, can you speak to vaginal pH test versus urine pH test in investigating BV?
So because what you want to actually see is the discharge, is the pH has changed in the vagina. The pH of the urine can actually be separate. So for accuracy, when you're using that Amstel's criteria, and it's actually really easy. You just get your cotton swab, you get whatever discharge you can from the vagina, and then you put it on your testing strips. So you have to have pH testing strips. I know we used to just have that litmus paper when I worked at Melbourne Sexual Health Centre. Admittedly, that was 15 years ago. I'm sure they're more sophisticated now, so they can actually tell the right values. But you know, it is actually easy. You just want to see that you've got an increase in that pH greater than 4.5. So it's actually a really easy test to do. So you don't use the urine dipstick, because that would be looking at the pH of your actual urine coming from urethra versus the actual vaginal discharge.
Great. Melanie also says, love your earrings,
I
Siobhan.
know I wore them, particularly my my clitoris earrings. It was a big toss up today. I have IUD earrings, and I also now have abortion earrings. So I have Miffy and Mizo. So it's a big toss up as to what earrings I was wearing. Anyway, thank you, Melanie.
Where are we up to? Sally, a question from patients. Is there evidence antibiotic use can predispose to BV?
No, there isn't any evidence that increased amount of antibiotics for other reasons will increase BV at this stage that I'm not aware of any. And the main thing would be, for me, is around thrush, but that's a very, very common thing. But yeah, I think we have spent a long period of our lives, for those of us who've been doing sexual health for a very long time, thinking that BV is not this STI. And I think now we have to flip our thinking and start saying it is an STI. Don't actually know what the bug is, but it is an STI, and therefore we need to treat it like we do with other STIs. We're just at the beginning of this research, and we need to work out how it is that we're going to talk to patients and how it is that we are going to what are going to be the guidelines of contact tracing, partner notification, etc. And I think that's the things that we're going to see more and more evidence of over the next few years.
Great, thank you. Does a symptomatic female partner of a female needs treatment? What is the treatment regime?
So there's a new bit of research that Katrina's team is doing. I think it's called Step Up, and they're doing the research on female partners. I think from what Katrina has said so far is that it seems like the evidence will be that yes, treat symptomatic or asymptomatic partners and I presume that the regimes will be similar. So there will be that choice of oral, metronidazole, all the vaginal preparations for the partner. If that makes sense. I hope I said that correctly.
Excellent. We're almost out of time, but I think we've just got two more. Kate, I have seen a few people recently with deep dyspareunia. I don't know if I've pronounced that.
Dyspareunia. Yep.
That's right. Who have an IUD plus BV. The traditional thinking is BV is painless, but if there is cervical inflammation, could it cause dyspareunia? Also, should we be treating asymptomatic BV in people with an IUD to prevent PID?
Yes, I would. Yes to the last bit. And I think probably you need to work out whether the dyspareunia is deep and therefore evidence of PID and therefore definitely be treating, and or whether it's more superficial and so therefore is that a vaginismus or something along those lines. But the evidence definitely shows not that you don't have to remove the IUD. So you can treat the BV before you don't remove the IUD as part of the treatment. But yes, I would definitely be treating someone for their BV with an IUD, and particularly if they had dyspareunia, I'd be trying to unpack whether that was higher up. And I must say, most people that I have ever spoken to about the potential of having a deeper infection, because it's virtually impossible to actually diagnose PID without doing surgery and seeing that the tubes are inflamed and have pus in them. And the majority of people that I would say just accept the fact that I'll treat your PID. Sorry, I'm getting a bit muddled. I'll treat your PID. But I can't fully diagnose it. I'm diagnosing this on clinical assessment of what you're telling me and what the examination is. And what I'm trying to do is save the tubes from further sequelae of being blocked and infertility. And I have not had a single person say, no, I don't want the treatment. They normally say, yep, I'll take it, even though it is 2 weeks for full PID treatment. If that makes sense. Sorry, I went round and round and round in a circle then.
That's
Yeah.
great. And there's just one more. Just a thought, can you use the pH from urinalysis stick and put the vaginal discharge on it to assess pH of vaginal fluid?
Well, if it was the only thing I had there, I'd give it a go and see whether it does work. I can't imagine that it wouldn't, because really all those things are doing is detecting whatever fluid is on them and the change in the pH. I would give it a go, but yeah, that's something that I'd probably have to ask Katrina or ask ask your pathology lab if they have any evidence of it. But I don't think that there is any issue, and I would get from your medical supplier where it is that you've got some sort of pH paper that you can actually put any type of fluid on. I think that's all they are. There's nothing more exciting, but I'd give it a go if that's what you've got. Yeah.
Excellent.
And
Um,
yeah, litmus tests are not routinely stocked. So yeah, so we might actually have to move on to other things.
mm.
There clearly are in, science experiments at high schools. It's the same stuff.
Thank you so much, Siobhan, for such a fantastic, comprehensive presentation. I think on speaking on behalf of everyone, I know that there's been lots of comments and questions, and we really appreciate everyone who's commented and getting involved and for joining us today. Um, Thank you all again. So have a wonderful afternoon, and thank you again, Siobhan.
See you.
Take
Bye.
care.